And about, I don't know, somewhere between 7 to 10 years ago, especially when Johns Hopkins started getting some traction with their psilocybin at end of life, progress with their clinical trials, Johns Hopkins and NYU, it started listening again and started following it. And at some point, realized that, that there was a merger coming in, that these things were going to come back together, that you could start to see that the momentum was likely going to happen. And people were starting to talk about it more openly. I was at a dinner with a number of colleagues, all physicians, and at that time I had just come back from Peru, from doing ayahuasca in Peru, where it's a legal medicine, and worked with 2 PhD therapists there, and had a great time. Had really great sessions. I came back renewed, reinvigorated. And I was telling my colleagues, they said, "Oh, well, you're in Peru. What were you doing?" And I said, "Well, I was down there doing ayahuasca." And, it was kind of the first time I said it aloud to my medical colleagues. And it turned out that all of them had also done ayahuasca. And then we laughed our heads off about how we had essentially had silenced ourselves from speaking honestly about the personal sides of our lives. And so we started talking about it and just kept talking about it. And, one thing leads to another. I was trained, I did a lot of training in ketamine assisted therapy. I had some great mentors and some great programs. And I was working in chronic pain, and realized, again, there's another intersection here that, chronic pain in people is probably, give or take a few percentages in either way, 50% physical, and the other 50% is emotional. Like we're fully connected people, brain and body. And I wanted to bring the ketamine therapy into the chronic pain program, because I knew I could only get people so much better with their pain, but I wouldn't be able to get rid of their fibromyalgia pain if nobody had ever dealt with their rape or their trauma. And if we don't deal with the whole person, then pain is going to manifest in the body. And there's a lot more data around that now. There wasn't so much back then. And so one step, again, just mycelial threads hanging there just all started to coalesce and come together. And then we were able to, push the leading edge a little bit and bring psychedelics into an existing program called Roots to Thrive. That was a resiliency program for healthcare workers, frontline healthcare workers, doctors and nurses, that had been developed by Dr. Shannon Dames at Vancouver Island University. And we married the program. We knew that we could do better. We could get better outcomes with people facing trauma, PTSD, burnout. And so that's where we went. We did that. We've been publishing on our outcomes, and we've been able to add in a psilocybin arm as well to the program.
Wow, that's fantastic. I mean, that's such an amazing journey. And it's like everything that you were doing in your life actually brought you back to full circle to what you've been doing. I mean, you have the background in criminology, so you had that idea of the difference between the sociological aspect of it and the criminalization of it, how that intersects. And then also being somebody who worked in, as a firefighter. So you had that experience there dealing with trauma and understanding that. Then your science background and being a doctor. And then it's interesting that your fellow physicians are, did a little conscious traveling themselves using ayahuasca themselves. Now, one of the things I was always interested in is there really a difference in different psychedelics, or like, let's say ayahuasca versus mushrooms? Do they do the same thing, or it's just based on potency? How does that work?
I'm definitely not an expert in that area. So take what I say as just my experience and knowing with the knowledge that I have. And of course, there's other people that would be much more knowledgeable about this than I am. I think what we'll find over time, and if we maybe hadn't had this 40-year hiatus of the war on drugs, we'd be a lot further along of knowing, at what point would you use which medicine for what reason. I think they all overlap. There's a lot of Venn diagrams that go. I think of, and again, this is based on some research and some personal and some experiential and anecdotal and case studies and stuff. Like medicines like ayahuasca, I think do very, very well for big transformations. And I know in South America, there's in fact some hospitals that use ayahuasca first and foremost for some, even metabolic diseases like diabetes, and for some people that have been sent home and said, you got stage 4 cancer, there's nothing more we can do. They go and do ayahuasca and find their way back to health. So there's, you hear stuff like that. Then you have, mescaline type, the cactuses like peyote and San Pedro. And I think those are a lot lighter, maybe a bit more creative type substances. And then you have psilocybin, which is a mushroom, that can be used on multiple levels. I mean, before the war on drugs, it was being used successfully for alcoholism and depression, and probably a lot of other substance uses, disorders. And it's great for deep trauma, for PTSD, and obviously end of life distress. And then you got LSD. I don't know that much about LSD. I can't really speak well on it. And then ketamine, which of course has been on the WHO's list of essential medications for a very long time, been around since the 60s. And, we use it for multiple reasons. We use it in the emergency for trauma. We use it in the OR for operations. And then it's got this wonderful benefit that it can also help for trauma and depression and OCD and anxiety. So I'm not really answering your question because I think there's so many intersecting Venn diagrams of all these medicines. And I think, like, again, if we hadn't had this hiatus of 40 years, we might have a lot better understanding, like, oh yeah, you should do this first, and then you should do this. And I think we're starting to tease that out as we return to some knowledge. And I keep in mind, many of the psychedelics are also molecules. They're lab synthesized molecules. They weren't around. They're newish in the last 100 years or so. So.
Yeah, like I just find it so fascinating on the information too as well. I mean, like, yeah, we can go down different directions like this. I was just hoping to have a conversation and just get the information out there. There's a lot of misinformation. But there's also a lot of information that's starting to surface now about the different things. And I had watched the video on, I forget where it was, but it was basically on using ketamine therapy for PTSD.
Mm-hmm.
And how effective it has been, especially they were talking about some soldiers who witnessed horrific, and seen horrific stuff during Afghanistan, and they come back and they just can't get their life back together. Mm-hmm. And the use of ketamine therapy. Now, for me, my understanding of ketamine therapy was more of a sedative, but it's also a hallucinogen too as well.
Well, it has a psychedelic range. It's a psychedelic-like medicine. And so it's all about dose on these sort of things. So at a very low dose, I could, if you came into the ER and needed stitches, I can give you a very low dose and it'll help the pain and it'll help you feel just light and won't be traumatizing. We can give you some nice sutures and you can go home. If you have a broken arm, like kids and stuff, I used ketamine in the ER all the time for kids, broken arms, and they're just like be screaming. You give them some ketamine and they're like in happy land, and you can fix their arm and they're not traumatized, which is nice, right? They're not traumatized from being in the ER and all the noise and distractions. And then there's the psychedelic dose, which is higher than that. So somewhere around 1 milligram to 1.5 milligrams per kilo, approximately. Remember, it's not really a weight-based medication. It is more of a receptor-based medication. And then you've got quite a bit higher, which is what you'd want if you were getting an operation. We are completely out. You're anesthetized. You don't feel the pain, and you don't have any trauma from the procedure. So it's all about dose in that case. But its on-label use is as an anesthetic. Okay. Its off-label use is, it's on-label now for Spravato, which went through the clinical trials to get the intranasal, but you can equally, for 1/10 the cost, you can get intranasal prescriptions of ketamine for that too. So the on-label uses, like the official use that it's gone through clinical trials for, is depression and as an anesthetic, but we get clinical evidence that shows that, it also helps for depression, and it can also help for anxiety, and it can also help for PTSD.